Okay, hello everyone. Welcome to our next presentation in the Silver Zone, where we have Jules Levin, who is the founder in 1996 and executive director of the National AIDS Treatment Advocacy Project, NATAP, in New York City. As a person living with HIV and hepatitis, he's well aware of the importance of having access to quality, current treatment information, as well as having a group that will advocate and lobby on behalf of the community. NATAP's website and other programs provide conference coverage, information, education, and advocacy globally on HIV, including aging with HIV, as well as hepatitis. So welcome, Jules, over to you.
Thank you, Kate. And as you can see, the title of my talk says a lot about how I feel about this problem. And I know many people feel the same way. The arc of aging with HIV from 1996, that's when protease inhibitors first became available, to 2022, where we are now 25 years later. From promise back in 1996 to disappointment and despair that many of us feel today. So what I'm talking about is that in 1996, we had the promise of HAART and multi-drug regimens that many of us thought was the answer and would really lead us to a great future. And I think what we find today, 25 years later, is that we have what we have now, we did not expect. We did not expect to age the way we're aging. We did not expect to be experiencing what we're experiencing. One of the problems is that many people have been surprised and shocked by all of this because their doctors and the federal government in the United States and governments all around the world were giving them misleading messages. No one was telling them that they were having more comorbidities than people without HIV. No one was telling them they were experiencing premature aging. So very often a patient would go to their doctor's office and have a fracture, and the doctor would tell them, well, we're experiencing people getting fractures earlier, aging earlier with HIV. And patients are shocked because they never heard that before. And then you have governments and researchers telling people that mortality is the same for us as it is for the general population. I'm going to show you that's just not true. And many people just don't understand what's going on. So in response to some of the concerns I've raised, so what we have is, there are three problems. Number one, we need new models of care. The models of care we have just aren't working for us now. Number two, we need better research to try and understand what's going on, to try and prevent aging prematurely. And number three, we need researchers and governments, local and federal, to really address this problem. And researchers are not always our best supporters, as many people think they are. And one of them told me recently that marginalized people with HIV did not have HIV care before the Ryan White Care Act, the system in the United States. So now that they have the Ryan White Care Act in clinics, at least they're getting care, and that should be good enough. Needless to say, I'm not pleased with that response, but a lot of people feel that way. I'm not going to read this whole thing. It's all on my website. So here is from the CDC in the United States showing that back in 2018 or 19, that's when this study was from, that there were over 200,000 people over the age of 60 This is expected to double by 2030. So we'll have 400,000 people over 60 by 2030. So this is what I was telling you about mortality. This is from a major study presented at CROI just a couple of years ago. Everybody saw it. Everybody knows about it, including the researchers and government officials, showing 9 years less life expectancy for people with HIV. And for people with a higher nadir CD4 count, the gap was only 6 years. Inflammation is associated with mortality, excuse me, for people with HIV. Are there sex differences? I'm going to show you there are. People from the same study, people with HIV are shown to have earlier onset for comorbidities. And strikingly, the range is from 9 years for cardiovascular disease in the right-hand lower corner to 24 years for liver disease, 16 years for chronic kidney disease. What this means is that on average, in this large, very large study from a very large insurance database in the United States, people with HIV were getting chronic kidney disease, for example, on average 16 years earlier than people without HIV. Chronic lung disease 15 years earlier. Diabetes 7 years earlier. Cancer 10 years earlier. Heart disease 9 years earlier. And this is in table format showing you the same thing. I'm not going to spend too much time on each slide because I'm pressed for time here. But these slides are all available to you. I don't know if Kate's going to make them available, but they're all available on my website, or I'm glad to share them with you. So here's another study on increased mortality for Blacks with HIV, African Americans. This was a study in the United States. If you look at the panel on the left, you'll see Black men and Black women have higher rates of mortality than white men and white women. And if you look at the panel on the right, heterosexual females and heterosexual men have higher mortality than men who have sex with men from the same study. This is a study from a Danish study from people with HIV. And I circled in red group 3. Group 3 is the group that have comorbidities, and they have 70% probability of reduced survival. So this study shows that multi-comorbidity reduces survival in people with HIV. Now, this is a study from Medicare in the United States, but not people with HIV, just to show you that just having comorbidities alone, if you look where I put the purple marks, say, look, for example, at a white person 70 years old, and you can see that if they have high numbers of comorbidities compared to none, the difference is about 7 years in life expectancy, 7 years less life expectancy. And for Black people, it's about the same. Actually, for Black people, it's 3 years, a little less, but still there's loss of life expectancy just due to having comorbidities ranging from 2 to 9 years. Just to review and capture it all at once, like I said, we're going to have 400,000 people in the United States alone over 60 by 2030. In New York City and San Francisco, already right now, 30 to 35% are over 65. So by 2030, it'll be 50 to 55% of people. NASH, fatty liver disease, non-viral hepatitis is a comorbidity. People with HIV have 2 to 5 times more comorbidities than people without HIV. That includes heart disease, cancers, bone disease, liver disease, chronic kidney disease, fatty liver disease or NASH, and chronic pain, which is associated with neuropathy. It doesn't get attention either. And earlier onset is on average often by 10 to 15 years. We suffer double rates of falls, fractures, and frailty. Bone DEX is the only way to evaluate if somebody has osteoporosis, is in general not performed in HIV clinics in the United States, and I would guess anywhere in the world. We're suffering earlier onset and higher rates of cognitive impairment and physical disability. We suffer higher rates of muscle dysfunction or sarcopenia, worse fat metabolism. Fat metabolism dysfunction is a signature of HIV. We suffer immune dysfunction and senescence. Those are the reasons that we're experiencing premature or accelerated aging. And we're suffering significant functional impairment as we age, which is reflected in our higher rates of problems with independent activities of daily living, which I'm going to review. Who are the most vulnerable people with HIV? Women, the elderly over 65 and more over 70, African Americans, Latinos, the transgender community, and anyone more marginalized who has less access and more problems with social determinants of health, which is essentially all of us. This was a study out of France a couple of years ago, presented at CROI, just to give you a sense of the difference between people over 75 and 50 to 75. And if you look, you can see people over 75 with HIV have 2 to 3 times the higher rates of comorbidities compared to people 65. Just to show you what happens as we age over 70, it gets worse. So if you're in your 50s, this is what many of us have to look forward to when you reach 75. I hope this brings a sense of urgency to your thinking about our needs. This was a major study out of a major clinic, the Cornell Hospital in New York. And what I want to bring to your attention here is that they have a geriatric clinic. This came out of the geriatric clinic at Cornell. And if you look at the bottom of the table, what I'm showing you is here, what I circled in orange is that high-risk comorbidities and functional comorbidities. In other words, people who had functional comorbidities, they had problems walking, performing normal daily living activities of daily living. And you could see people over 65 and over 70 had 3 times higher rates of functional comorbidities and high-risk comorbidities compared to younger people who are 50 or 65. Now, I know this is a busy slide, and I'm not going to go through all of this, but this is just a list of all the comorbidities that people had. And some of the high-risk comorbidities are cancers, bone disease, cerebrovascular disease, cardiovascular disease. And look at some of the high rates some of these people had. 78% of people in general had cardiovascular disease. 100% of people over 75, 89% of people 65 to 74 had cardiovascular disease. And neurologic disease, 43% over 75 had neurologic disease. This is what elderly people with HIV, and I mean people over 65 and over 70, are facing today. Let's turn to women. Women have a higher comorbidity burden. Part of it's due to menopause. Menopause gets little attention and discussion, but increasing with age, women are experiencing more comorbidities. And if you look at the table, the graph on the left, you could see as women age, compared to HIV negative women, you could see the dark blue bars. The number of people with more than 4 comorbidities increases a lot as women age from 40 up to 60. And compared to HIV negative people, it's much higher. And if you look at the graph on the right, you can see as they age, HIV positive women with the red bars too. But what I bring to your attention, if you look at to the left in that panel, women under 40, women with HIV under 40 coming into care also have higher rates of comorbidities than HIV negative women, showing the need for special care for women in the clinic and in our care situations. We don't have special care for women, and they need it. Frailty, people with HIV and frailty. We have double the rates of frailty. This is the MAX study. This is a big study in the United States, a large national study of men who have sex with men. And bring your attention to the right side of this panel. Men over 65 with HIV, that's the black bar. They have double the rates of men without HIV for frailty. And if you could see over 50, they all along the way, they have double the rates. But if you look at men over 65, 25% of men over 65 with HIV have frailty. And this is similar for women with HIV from the WISE study, which is the large national study of women with HIV in the United States. This is another study that was presented a couple of years ago at CROI, showing the prevalence of frailty for people with HIV. And you can see in the orange bars, 41% of people had pre-frailty. And in this study, 5.7% were frail. What I'd like to bring to your attention here in this graph is the middle, the two graphs in the middle, looking at HIV positives versus HIV negatives, and one is men and one is women. I forget which is which. I think the women is on the left and the men is on the right. But what the stark comparison between HIV negatives, which is the black, versus the gray, which is HIV positive, you could see over 50 and over 40, you could see the stark, sharp increases in the rates of fractures for people with HIV compared to HIV negative people. And you could see as people with HIV age from 50 to their 70s, that difference between HIV positives and HIV negatives just continues to widen very appreciably, showing the fracture, the influence, and how many fractures that we experience as we age, people with HIV. Very worrisome. The impact of fractures is underestimated. I'm going to show you why. Fractures are 2 times higher for people with HIV. And here's falls. You can see the people, how as we age, the increase in the number of falls that people with HIV experience. And it really is a sharp increase from 40 to 60, double the number of falls. I know lots of people who are experiencing not just falls, but they experience multiple falls, recurrent falls all the time. It's very common in elderly people with HIV. Now, what I wanted to show you is why falls and fractures are underestimated is that fractures are associated with mortality. And you can see circled in red here that fractures increase mortality 47% in people with HIV. So having osteoporosis and not getting a bone DEXA to be identified with that, and having premature fractures translates into premature frailty and can translate into premature mortality. Again, getting back to women. This is similar to what I showed you before, but this is a slightly different study, but showing that women also, again, have 5 or more comorbidities, more so as they age past 60 and past 70. And you can look, the panel on the bottom is women and men with HIV. And so this is not just women, it's men and women. And if you look at the prevalence of 5 or more comorbidities for men versus HIV negatives above them, look at in the dark blue, look at the difference between, it's almost double for men with HIV over 70 and over 60, and for women as well. Getting back to women, this is actually from the Athena cohort presented at Glasgow a few years ago, showing that relative to men, women had higher multimorbidity and mortality. Aging women compared to aging men. And you could see the mortality. And what this study also showed you was, this was one of the first studies to show you, if you look at the table and you look at the multimorbidities, for every increase by 1 in a comorbidity that a person had, the rate of mortality increased significantly, showing that the more multimorbidities that a person has, the higher the rate of mortality. So much for us having the same life expectancy as people without HIV. This was a study showing that women with HIV have relative 5 times higher rates of myocardial infarction, heart disease, women with HIV compared to HIV negative women. And this was an old study from many years ago showing myocardial infarction for people with HIV, heart disease, the rates of compared to HIV negative, and the same trend occurs. The gray line is people with HIV, the black line is people without HIV. And you see, as we age, the sharp differences and the increasing differences between us, the higher rates that we experience as we age compared to HIV negatives. Getting back to women with diabetes, showing the higher rates of women over 65 for diabetes in the green on the right compared to HIV negatives. It's 40% versus 27% for women without HIV. A very big problem, diabetes management for women with HIV here in New York City. Cognitive impairment. It's estimated that about 30 to 40% of people experience cognitive impairment, either asymptomatic or mild cognitive impairment. I'm not going to go into this in much at all, but the issue and the understanding around cognitive impairment is very confusing, and many people just don't understand what it really means. It can be very mild. Many people don't even realize they have it. Women have higher rates of inflammation markers than men with HIV. This was a study at Croy from a couple of years ago showing that women have higher levels of inflammation markers than men. This is one of the reasons that they experience more comorbidities. It's probably related to menopause. Now, this is an interesting study from New York City. And the only reason that you have this, I'm showing you this, and that New York City has this data is because probably no one else is collecting this kind of data. But I'm sure this is true all over. And what it says here is that in New York City, the all-cause death rate among people with HIV is double the rate for the general population in New York City, 8.9 per 1,000 versus 5.5 per 1,000 for the general population. But what I show you of note here is that the cause of death in New York City, the greatest cause for people with HIV is 25% AIDS. But right after that, if you look on the table, all the way on the right, just below the 25%, the second leading cause of death for people with HIV is cardiovascular disease, 19%, and then cancer, 18%. So I want to get back to what I mentioned before, this capacity, this incapacity to perform normal daily living activities. What does this mean for people who are aging and who are experiencing pre-frailty or frailty? Well, this was a study from the ACTG in the United States showing exactly what kinds of daily activities we're able to perform less well as we age. Housekeeping, transportation, getting around, shopping, actually going to the store and shopping, laundry. This was a survey performed in people with HIV who were older, and they reported having difficulty performing these daily activities, managing their finances on a daily basis, cooking, using the phone. They had problem using the phone. They had difficulty with medications. Now, these may be words to some of you who aren't experiencing this, but I can tell you that this is all true. Many people over 65 have trouble actually using the phone, cooking, shopping, getting around, doing laundry, just daily living, normal activities. In fact, this was a study from the same group, the ACTG, showing that we, people with HIV, you look at the table on the right, as we age even more, we experience 2 to 5 times higher rates of worse daily functioning, and it gets worse as we age from 45 to 74. And it's worse compared to the NHANES control group on the left. The HIV positives are on the right. This was another study that came from the famous San Francisco SCOPE cohort showing the same things, similar things. Falls 25%, frailty 9%, mobility 22% impairments. Mobility means you can't get around. You're walking with a cane maybe. You have difficulty performing, getting around, going to the clinic. Visual impairment 34%, depression 40%. Cognitive impairment reported by patient, these are patient surveys, 46%. Pre-frailty, 56%. 41% did reporting a fall in the past year. 60% reported mild symptoms of loneliness. 50% reporting low social support. 34% reporting possible mild cognitive impairment. 60% of people over 60 had higher frequencies of problems with balance in walking, 47% versus 33% in the younger group, who are 50 to 59. And people over 60 reporting worse gait speed. So this is the aging and HIV syndrome. I'm not going to go into all of this, but these are the constellation of issues that we're all facing. Now, you could be 45 and you could be 50, and you may be experiencing none of these, or maybe you're experiencing some of these. But many people over 65 are experiencing all of these. This is a very important thing that many people don't understand. This slide represents what happens to older people in general who experience a decline as they age, over 50 generally. You may be doing fine, and how one comorbidity or one incident changes everything. So you may not have had anything ever happen to you, but one incident can change everything. Let's just say you have a heart attack. Your quality of life and physical function can decline. Let's just say you get COVID. It can decline further. Let's just say you have a hip fracture after that. It can decline even further. Let's just say then you have a stroke. It can decline even further. The constellation of all these incidents for people over 65 who have increasingly have these kinds of incidents have a devastating effect on physical and mental function. The $64,000 question is, will younger people who started art earlier with 500 or 400 or 350 CD4s with higher CD4 natives, will they still suffer the same outcomes? Well, in my opinion, yes, they will. Of course, we don't know because they're still younger. They're not there yet, but they suffer many of the same things that cause the problem. But many of these younger people don't think they will, so they don't support us and our problems. They would rather talk about PrEP and cure, and there's a lot of ageism directed towards us. They studies show that immune derangement and immune exhaustion starts with HIV infection and accumulates for years. So does immunosenescence. Many people have genetic predispositions towards comorbidities. And actually, 40% of people in the United States are not in care. So they have detectable viral load, which increases predisposition towards developing comorbidities. Many people, no matter when you start ART, have been subjected to lifetime trauma, marginalization, and poverty. So many of these issues that I'm talking about here, immune derangement, immune exhaustion, these things occur no matter when you start heart, at a higher CD4 or lower CD4. Now, the effect may be less, so there may be less problems, but there still will be a problem, in my opinion. So what are the, just to recap a little bit, what are the daily problems and the barriers elderly people face? Internal stigma. The internal stigma is severe. External stigma is severe. Many people are functionally impaired, cognitively impaired. They experience anxiety. They're worried about the future. They've experienced lifetime trauma, abandonment. They feel abandoned because they're not getting the care they need. They feel abandoned by the community and younger people. They're experiencing polypharmacy. Some people are taking as many 20 medications a day. They're experiencing increasing irritability and agitation, as many elderly people do, HIV positive or negative. They have problems expressing themselves. That's cognitive impairment. They have problems communicating. Many people feel it's a death sentence. They have suicidal ideation. Our HIV healthcare system is broken. The HIV healthcare system is broken. We're not prepared for what's happening now and the future silver tsunami. We're not preparing for the future. We're not prepared. Many people don't understand the aging phenomenon. It's not receiving and federal attention. The biggest problem, which many people don't understand, is the 20-minute doctor visit, which has been caused by reimbursement by insurance companies. It's restricted care, and hospitals and clinics in the United States, and I assume elsewhere, they only are allowed to do 20-minute visits for the patient. And doctors are overwhelmed and underpaid, and reimbursement has been so restricted by insurance companies that 20 minutes is not enough time to address the problems for people who are aging with multi-comorbidities. Now, whether you believe it or not, this is the biggest impediment to getting the care that people need. There's no care coordination due to this and other reasons. People have limited access to physical therapy and mental health care services. Many have returned to substance abuse because they're so overwhelmed with aging and comorbidities. They can't get bone DEXAs. They're getting inadequate cardiovascular disease evaluation and treatment. Our state and federal officials are oblivious. Nursing homes are people with HIV, elderly people with HIV, the rates of them being put in nursing homes recently, in recent years, has doubled in the United States. How will we deliver care for the disabled elderly? This is not even being discussed at all. We need new models of care. In New York, several new HIV geriatric clinics have been opened. In my opinion, this is not necessarily the answer, but the reason that this is being done is because it's the only way to get reimbursement, is to take care, geriatric care, out of the HIV clinic, make it a separate clinic, and then they can get reimbursed for it. So it helps and it works, but it's not the answer. So thank you for listening. I don't know if we have time for comments or questions.
Hi, Jules. I'm here. Can you stop sharing your slideshow and then you'll show up big on the screen? There you go. Okay, so we did have a question in the chat, which was Axel wondering, is there a direct cause effect in terms of the number and severity of comorbidities and detectable viral load, which is high in the US?
Yes, I mentioned that. There's been studies showing that people who are not in care or people with detectable viral load, you know, if you're not in care, you're going to have detectable viral load. But yes, people with detectable viral load are more susceptible to getting comorbidities. No doubt about it. Cardiovascular disease, bone disease, cognitive impairment for sure. If you have detectable viral load, you are at much greater risk for those comorbidities.
Thanks, Jules. Anyone else have any questions? No? Okay, thank you so much, Jules. We appreciate you joining us virtually. Have a great rest of the weekend.
Hi, Giovanni. Thank you, Kate.
Bye.